اي. اعتقد دي السنه الثالثه اعتقد للمؤتمر، والسيشنز اعتقد وفي كاردياك ام ار دايما يعني بتبقى مميزه جدا جدا بحضور التشير بيرسونز، وعلى راسهم استاذنا الاستاذ الدكتور وحيد طنطاوي. فطبعا فليتفضل يا فندم. واسماء التشير بيرسونز حسب الالفابيتيكال، دكتور طبعا الاستاذ الدكتور احمد سمير استاذ الاشعه بكليه جامعه عين شمس، ويشرفنا كمان وجود دكتوره لمياء جمجوم المملكه العربيه السعوديه اعتقد، والدكتوره سميره سرايا استاذ الاشعه بكليه طب القصر العيني، الدكتوره سهى رميح اعتقد هي معتذره للاسف، ودكتور وليد محافظه ايوه حضرتك الاردن، من الاردن الشقيق، اهلا وسهلا، والدكتور وسام الموزي. نامل اعتقد ان هيكون السيشنز اعتقد مور بينيفيت، لان السبيكرز ايمننت فيجرز في السي ام ار اي او الكاردياك ام ار اي. اتفضل يا فندم.
Thank you very much دكتور مدحت. طبعا احنا بنعتذر عن التاخير ال 1 hour and a half اللي هو خارج عن ارادتنا. We'll try to go as fast as possible. وطبعا برحب بكل chairmans وبشكر الكوميتي for organizing this nice session. We'll be covering very important topics في ال cardiac MRI. And it is my pleasure to introduce Dr. Reem Mohammed from معهد القلب, and she will be giving us an introductory lecture about role of cardiac MRI in infiltrative cardiomyopathy in general. Dr. Reem.
Hello everyone. I would like to start first by thanking everyone for taking their time to attend our session today. Special thanks to Dr. Mary Rabia for moderating this session, and to our respectable chairpersons. We are going to start to talk about the role of cardiac MRI in infiltrative heart disease. Infiltrative heart disease are a group of disease characterized by abnormal deposition of substance like proteins, iron, glycogen in the myocardium. The infiltration can be extracellular or intracellular. Intracellular deposition disease are also called myocardial storage disorders. Myocardial infiltration generates inflammatory response that progress to fibrosis. Common pathological process we see in infiltrative heart diseases include increased wall thickness and inflammation that end in fibrosis and disruption of the conduction system if the infiltration is near the conduction system. We also see valvular disorders in infiltration of the papillary muscle. Some infiltrative diseases increase the ventricular wall thickness, while others cause chamber enlargements with secondary wall thinning. Advanced patients present with heart failure and cardiac arrhythmias. Infiltrative heart diseases is a form of restrictive cardiomyopathy when the abnormal substance infiltrates the myocardium. The ventricles become stiff, and there is impaired relaxation of the ventricles and impaired ventricular filling. So the stiff ventricles lead to increased ventricular filling pressure. So the atria have to work to do extra work to push the blood against this high pressure, leading to biatrial dilatation. Endomyocardial biopsy is considered the gold standard for diagnosis. However, it is invasive procedure with associated risks, and there is limited sensitivity in diseases where there is patchy involvement of the myocardium. So biopsy is being gradually replaced by cardiac imaging, especially cardiac MRI, for the initial diagnosis, risk stratification, and guidance of therapeutic decisions. Why do we use cardiac MRI? It is excellent modality for characterization of the myocardium. It can detect different infiltrative disease and differentiate between them. It can differentiate infiltrative cardiomyopathies from other types of cardiomyopathies, and it can stratify patients according to high risk for heart failure and arrhythmias. It is also used in monitoring patients to track the progression of disease and response to treatment. Cardiac MRI is used to differentiate restrictive cardiomyopathies in infiltrative diseases from other conditions like hypertrophic cardiomyopathies. Both have enlarged thickening of the heart muscles, but hypertrophic cardiomyopathy is does not show the restrictive pattern of restrictive cardiomyopathies. It is also used to differentiate infiltrative diseases from constrictive pericarditis, where there is a restrictive pattern, but due to a disease in the pericardium. It is also used to differentiate restrictive cardiomyopathy from cardiac tamponade, which is a disease caused because of accumulating of fluid around the heart. For this, for differentiating of restrictive cardiomyopathy from constrictive pericarditis, we use a very important sequence called the free breathing short axis real-time bright blood cine. It is acquired while the patient is breathing, so to look for paradoxical movement of the interventricular septum, which is seen in constrictive pericarditis. As we can see here, this is the paradoxical movement of the interventricular septum with inspiration towards the left ventricle, causing a decrease in the size of the LV chamber. This is an overview of the diseases that we are talking about. There are common diseases like cardiac amyloidosis, which may be hereditary or acquired. It is extracellular deposition of misfolded proteins. Anderson and Fabry disease, which are genetic disorders characterized by accumulation of glycosphingolipids. Sarcoidosis, which is non-caseating granulomas in multiple organs, including the heart. Iron overload cardiomyopathy, which may be primary in genetic disorders or secondary due to multiple blood transfusion. Uncommon infiltrative cardiomyopathies like Danon disease, which is a genetic disorders, or other rare infiltrative diseases like Pompe diseases and PRKAG2. The protocol we use in infiltrative diseases in cardiac MRI, we begin by taking localizer images, axial and coronal sagittal images to assess extracardiac structures. We sometimes take T1 black blood for detailed anatomy. We look for adenopathies associated pleural effusion or pericardial effusion in infiltrative heart disease. Another important sequence we take are the cine images. We take 2-chamber, 3-chamber, and 4-chamber cine images. They are ECG-gated SSFP images. We use them to calculate the volume and the function, and they are moving sequences, so we can assess the wall thickness and if there is regional wall motion abnormalities. Here we can notice that there is a concentric left ventricular hypertrophy in the LV muscle, and there is biatrial enlargement and associated pleural and pericardial effusion. Another important sequence we take is the T2 weighted imaging to detect edema. The edema shows as hyperintensity, and it is important to differentiate acute diseases from chronic diseases. The most important sequences we take are the late gadolinium sequences. It is used to detect fibrosis. We inject gadolinium, and we take images after approximately 10 minutes. The gadolinium washes in and washes out rapidly in the normal myocardium. And but in fibrosis, the gadolinium washes in and rapidly and washes out slowly. So fibrosis will enhance on late gadolinium images, while normal myocardium will appear black. To take good late gadolinium enhancement images, we have to first take TI scout images. These are a number of images that we take at different inversion times. We have to choose the best inversion time, the time at which the myocardium is nulled. Like here, for example, this is the appropriate nulling time of the myocardium. This is the nulled normal myocardium, and the blood pool is bright. However, while acquiring the TI scout of patient with amyloidosis, we noticed that the amyloid attracts all the gadolinium in the myocardium, causing suboptimal myocardial nulling or dark blood pool. Another important sequences we take are the native T1 and T2 mapping. The native T1 mapping is used for direct quantitative measurement of the T1 time of the tissue. It detects diffuse scar not visualized on late gadolinium images, and we use it to calculate the extracellular volume. It is used for measuring the extracellular matrix expansion. It is calculated from the pre-contrast and post-contrast T1 and the hematocrit. It increases with protein deposition and fibrosis and decreases with lipid and iron overload. The T2 star images are important sequences we take to quantify the T2 star of the myocardium. They are used to quantify the myocardial iron load and to monitor the iron in the myocardium. We can use it to measure the iron load also in the liver and the spleen. Take-home message is the cardiac MRI offers a non-invasive, comprehensive diagnostic imaging tool that helps in the diagnosis and decision-making, tracks the progression of diseases and response to treatment. Thank you.
Thank you very much, Dr. Reem, for this valuable and very important talk.